think that attention is finally being focused on this, and as much as cases like this are sometimes exaggerated in the media, I like that they get press and that people are thinking about it, which isn't, normally something that comes to mind. I don't think that we're very well prepared, and I think what we're missing the most are surveillance systems to detect truly resistant bacteria like this. The common antibiotics that are given for infections like this will be tested by most laboratories, but something like colistin is usually only tested when you see resistance to other bacteria and only by request. So it's unlikely that it would be detected just routinely by most laboratories in the United States unless people are looking for it. So surveillance is the most important thing. Probably one of the most important areas to look is actually in our food supply, and to do surveillance of the antibiotic-resistant bacteria that are in animals due to antibiotics in animal feed. What we need to do in order to prepare for outbreaks of antibiotic-resistant bacteria is really twofold. One sort of in the short term and one in the long term. In the short term, increased surveillance is essential. We need to know what we're dealing with, how frequently it's there, and in what areas, and what are the risk factors for certain types of resistant bacteria. By far and away, the biggest risk factor is antibiotic use. And it doesn't even matter in a lot of ways which antibiotics we talk about. Overall antibiotic use is a significant risk factor for resistance. And when you think about it, antibiotics are unique in that they're the only class of drugs that their use in one person affects their utility in another. So really they're a societal good. On the other hand, we also need to increase antibiotic development because when we lose colistin, which is not a very good drug, it's not one that you would want to receive. It's fairly toxic. It causes nephrotoxicity or kidney damage in a significant portion of people. But when we lose that, there's very little, if anything, behind it. And we need to incentivize antibiotic research and development, since many pharmaceutical companies have moved away from it because the treatment of an infection for 5 or 10 days with an antibiotic is not profitable relative to the treatment of, say, a chronic condition for years at a time, or the treatment of cancer for where we will treat with drugs that cost thousands and thousands of dollars. Okay, so what prescribers can do to avoid encouraging antibiotic-resistant bacteria is, frankly, to limit the use of antimicrobials to patients who most essentially need them. I'm not saying to not give them to patients who are truly sick, but the treatment of many types of infections is there's a lot of overprescribing for many different types of infections. And there's a large number of people who are not truly infected but receive a prescription anyway, particularly for upper respiratory tract infections, where it is very difficult to tell the difference between a viral infection and a bacterial infection. But also, sort of interestingly with this case, there are also a large number of people with bacteria in their urine who don't have infection, particularly patients in hospitals and nursing homes. Large proportions of those patients receive antibiotics as well, and every antibiotic use increases the potential to select for a resistant infection.